So I think we can start.
Okay.
So, good evening, everyone. Welcome to our first webinar. Thank you so much for joining. I know it was kind of changed last minute, but thank you all for joining over here. Today we had Dr. Bartosz Sokół. He's an assistant professor in the Department of Neurosurgery and Neurotraumatology at our university, and he's also the senior assistant at the Department of Neurosurgery in the Clinical Hospital at Przybyszewskiego. So we're thrilled to have you over, Doctor, with us, giving us a presentation. So without further ado, I'll pass it on to you.
All right. Thank you very much for allowing me to give this presentation. It's an honor. I I started my adventure with neurosurgery when I was your age, when I was in the first year of medical school, and I carry on since then. And I must say it's a wonderful journey. If you really enjoy it, it's definitely not boring. Therefore, I definitely recommend it to you. Uh, the idea of this presentation is just to give you the glimpse what neurosurgery is dealing with, and maybe you will find something particularly interesting in it for yourself. So, neurosurgery is obviously dealing with the brain and the spine. So, with the uh, with the brain, we have the certain disease which we can deal with, and this is purely the neurosurgical work. And then the spine, it's also the work which surprisingly is done by neurosurgeons. So there's plenty of things we can do for the patients with the spine problems. And in terms of the spine, the bread and butter of the neurosurgery is a degenerative disc disease. So we have multiple things happening with the spine, which can create the degeneration of the disc with the osteophyte formation, some thinning disc, disc herniation, bulging discs, and this is causing the compression on nerve roots, which is causing some symptoms. And this is where we are helpful that we can release the compression, and very frequently we can improve the quality of life. Uh, the next, like a more important thing from the spinal point of view, is the spinal trauma. We frequently see patients with some accidents, and we have to correct it. And very frequently, as you can see here, we cannot restore the neurological function of the patient because, as you can see, the spinal cord is severely damaged by the fracture. But when we operate those patients quickly, we can restore the stability of the spine, and therefore we can mobilize them quickly, and rather than laying flat for 6 months to allow it to heal, uh, we can try to mobilize them as soon as possible. So the spinal trauma is very essential area of the neurosurgery. Then the next case is the vascular problems with the spinal cord, with the insufficient blood supply, or uh, too much blood supply pouring through the spinal cord. Like you can see this dural IV fistula around here, which is abnormal disconnection between the spinal radicular artery and the perimedullary vein, and then this abnormal connection is creating the elevated pressure within the spinal cord, within the vein, which is draining the blood from the spinal cord. That is causing the blood congestion, and it's creating the ischemic changes. Therefore, we can correct these lesions and we can improve patients' quality of life. Next one is the oncology. This is quite this is very important area of the neurosurgery, as we very frequently can quickly restore patient function. So we have obviously people tend to survive much longer with the different diseases now, with the oncological diseases. But the spinal cord is the spine is the very frequent area where the oncological disease metastasize, and the patient presents with some sudden onset of neurological deficits, and we can help them. We can create more space for the spinal cord. We can remove lesions. We can decompress the spinal canal, or we can stabilize the fractured bone, which are damaged by the uh, tumor infiltrating the bone. So this is where we can be helpful as well. And then functional neurosurgery. So if the the last thing when we have patients with some failed surgeries, with some leg pain, very frequently they are left with some scars in the spine. We can try to also help them with some electronical devices like spinal cord stimulator, where we can create the sensation of tingling and reducing the pain coming from the lower limbs. We can insert a baclofen pump, which can be very helpful for different sort of spasms, or we can perform some rhizotomies to relieve the pain in the limbs. Then the brain, which is more obvious for neurosurgeons. So again, the bread and butter is the head trauma. So we have to deal with the different areas of the bleeding, post-traumatic bleeding into the brain. So we can have the epidural hematoma, subdural hematoma, some intracerebral hematomas with the bleeding into the brain. And then this is very rewarding procedure. Last week, for example, I was operating the young boy who was basically dying. He was unconscious. He had dilated pupil. His GCS was very pure. He needed to be tube ventilated, and we managed to operate him very quickly. And he recovered full function. So he's GCS 15. He's walking around, but 1-2 hours later he would pass away. So that's when you see such situations like this, it makes you feel very happy that you can and proud that you are chosen to do this profession. But also oncology, we frequently have to deal with different lesions. We have like superficial lesions, deep-seated lesions, lesions which are infiltrating brain, or they're just compressing on the brain, and we managed to remove quite a lot of them. Some of them need to be debugged to create more space. As you can see here, that the brain is so compressed and shifted that it's causing some neurological deficits. Sometimes when the tumor is located very deep, we cannot do anything with it. I just double check. Can you hear me well?
Yes, Professor, we hear you.
So if the tumor is located like a deep-seated lesion, we very frequently are not able to take this tumor without significant morbidity and mortality. But we can provide the option of the stereotactic biopsy, where we can stick a needle into it and we can give a diagnosis. And again, although we are not able to cure these patients, we can enable them to have a radiotherapy, chemotherapy, and definitely this sort of treatment prolongs life expectancy. Vascular neurosurgery, so there's a big shift. So in the past, it was the domain of neurosurgeons, which were dealing with the ruptured vessels, which are bleeding into the brain. So it required open surgery and clipping. Now it is more like the endovascular team, which can insert the stent. This is the neuroradiologists who are doing it. So they are inserting catheters, via which they deploy the coils, which are filling the aneurysm, and then they obstruct the flow of the blood through this ruptured aneurysm, and then they are securing it and preventing it from rebleeding. This is great progress, because in the past, very frequently the brain was so swollen we were not able to operate on those aneurysms quickly enough. Therefore, we have to be less aggressive with the treatment, and we could not very frequently. We had the rebleeds of these unsecured aneurysms, and the patients died. And the surgery was only possible if the swelling settled down. Whereas with these procedures, we don't have to wait for anything. The radiologist can insert the catheter into the aneurysms, and they can fill it with the coil, and the aneurysm is secured. And the hydrocephalus, the procedure, which is not might sound very very simple, but this is great procedure. This is the one of the most effective. So the putting the shunt is one of the most effective procedures in neurosurgery. We have patients who have the obstructed CSF flow from different reasons, like they have obstruction of the flow, they have obstruction of the absorption, they have a problem with the circulation, and the elevation of the intracranial pressure creates the neurological deterioration. So we frequently put the shunt, which we put the special catheter into the ventricle, then we put the drain into the, we drain this excess of the cerebrospinal fluid either to the abdominal cavity or to the heart, and we can release the pressure from the brain, and the children or adult people are doing very well. Also, elderly people who have the condition called normal pressure hydrocephalus will have problems with walking, memory, and urine incontinence. We have to do a couple of tests, and when we confirm the disease, when we put the shunt, they completely regain the function. So this is really impressive procedure, despite being not so complicated. The next one, functional neurosurgery. So we can monitor the different areas of the brain. We can look for the eloquent area and try to preserve them. We can put the deep brain stimulation for the Parkinson's disease. We can put the electrodes, and we can cure the patient. This is a great example. So this is the patient with Parkinson's disease. So you can see how severely disabled the patient is. He has a major tremor. So this is when the electrode is turned off. You can see how bad it is. And we see the patient over here. So this is just before the stimulation is turned on. And the neurologist is turning on the stimulation with the electrode placed into the brain. So you can see how the tremor is settling down. One second. Yeah, so we asked him. So this is the hand after the stimulation turned on, inserted, and this is the hand before. So you can see how spectacular it can improve patient function. Yeah, so this is very helpful. Yeah. So the history, it hasn't come from nothing. There's the generations of people who are working on different areas of knowledge before it's translated to the operating theater, before it's published, then it's widespread to the departments like us. So many people is working on progress in neurosurgery, and everything started in up to 6,000 years before the Christ. So Africa, pre-Columbian Mesoamerica, Egyptians, Greeks, Romans, they all knew that if you release the ghost from the head, hopefully the patient will get better. The first trepanation was performed in 7,000 years before the Christ in Kiev, in Ukraine, not far away from here. Another one was in like 5,000 years before the Christ in French region of Alsace. And most importantly, you can find this open skull, but very frequently there are proof that the skull has been healing. So it means that the patient has survived, which is even more exciting. So then there was another medieval trepanation in the 13th, 14th century. So this is the proof for the skills people possess. But then it went back to the the progress of the neurosurgery happened by this surgeon, Victor Horsley, British neurosurgeon from London, from Queen Square. So he was the first physician to remove the spinal tumor, and you can see those are his notes. So this is the first patient. He did some trepanations. He removed the tumor. Obviously, he didn't put the bone back, so very frequently they were not doing well. But this is the beginning. There are some drawings from his operating notes. So that you can see the spinal fracture, or here you can see the picture from the operating theater. So this is Victor Horsley, and those are the other people. Most interestingly, if you go to the Queen Square Hospital today, these theaters are still running. Maybe they look much more sophisticated, but this is the same area where they operated more than 120 years ago. The neurosurgeon who really made a progress in neurosurgery was Harvey Cushing. He was much more delicate than Victor Horsley. But he was also the great observer. So he encountered the Cushing reflex relationship between blood pressure and intracranial pressure. Obviously, you know the Cushing's disease and Cushing syndrome. And so this is where it is very widely known, but it is not known that he was the pioneer of the pituitary disease surgery. We have also some Polish pioneers in neurosurgery. So the creator of the Polish neurosurgery was Jerzy Chorubski. So he was the first neurosurgeon who traveled abroad. He went to McGill University in Montreal, and he was trained under Professor Wilder Penfield for 2 years. And also he was in Chicago Northwestern University Medical School from 32 to 34. So he gained a lot of experience. He came back and he brought it to Poland. Future of the neurosurgery. So we have the stem cells in regeneration for Parkinson's disease and psychiatric disorders. It is not very promising at the moment, but definitely people are working on it. So brain-computer interfaces, this is definitely the hot topic at the moment. As we know, it's already happening. People are already creating some connections, and they teach animals what they can do. There are some microelectrodes restoring bladder function. Nanotechnology with the nanomanipulation surgery at the level of the neuron or intracellularly. Nanoimaging at the cellular or subcellular level with the non-surgical nano repair axonal regeneration. Nanoneuromodulation with interacting with the nervous system function. This is very interesting, transcranial MRI-guided focused ultrasound surgery. So at the moment, like most non-invasive surgeries are related to the radiation, like a gamma knife or the Cyberknife, but this procedure utilizes the ultrasound, which is the direction and the frequency of the ultrasound is guided by the MRI, where we can choose the area of the brain where we want to direct the ultrasound, and we can warm up the area of the brain to reduce its function. And when we are happy with the results, we can warm it up higher, and then we can damage area of interest and creating some improvement. So it can be just the procedure which will replace the insertion of the deep brain stimulator into the like electrodes into the different areas of the brain. Cyberknife, so we can choose the area of interest where we want to radiate, and we can spare the rest of the brain, so we can apply multiple doses of the radiation, sparing the surrounding brain and administering the big dose of the radiation to this area of the brain. So this is definitely the improvement in the surgery. And this is the diagnostics is also very, very important. This is the CT scan of the first examination, first CT scan. So you can see how low was the resolution. Now we have the 9 Tesla MRI scans, which are very accurate, where we can really distinguish different areas of interest. So you can see this is the midbrain with the rubber nucleus, substantia nigra, and subthalamic nucleus, where we would like to insert the electrodes for the deep brain stimulation. So the resolution of this images is significantly improving. The next interesting area of the neuroscience is the working with the connectome. So we normally in the past we thought that the function of the brain is coming only from certain areas, but now we know that all the connections play the equally important role. So there are different examples of the people who had a brain injury during some trauma, which survived it, and then we managed to assess the injury of the brain and related to the different functions. So this is the Phineas Gage, the gentleman who had been hit by the iron stick into the brain. So the whole frontal area was damaged. He was completely changed after this accident. But scientists managed to reconstruct the area of the brain which was damaged just by reconstructing the skull and the entry of injury and the exit of the injury. And we found out that all the function which was damaged was related to these different areas, connections, the different tracts in the brain, like a frontal Aslan tract, uncinate process, frontal superior longitudinal process, frontal inferior longitudinal, and frontal orbital polar. Then there was another one, so the area of Broca. So probably you have heard the Broca area. So it was the physician who examined the patient, Louis Victor Leborn. So he was the young boy with the progressive paralysis and the aphasia. And Broca found out that he was observing this child, and when the child passed, then gentleman passed away, he examined the brain. So he had clearly described all the abnormal function within this boy, and then he took the brain out and he described the function. So he pointed out the area which he suspected was related to the Broca field. But then when the scientists managed to do the MRI scan with the tractography of it, they developed that it's not only the area itself which is damaged, but the whole tracts connecting different parts of the brain were damaged as well. And then another one, more recent, 1930s, Henry Molason with the multiple seizure attacks. So again, he developed, he was a young lad with the frequent seizures, and there was a neurosurgeon who performed the psychosurgical procedure on him, which created the immediate loss of the fresh memory. So he helped him to improve his seizures, but he completely lost the memory. And then again, we managed to look for different tracts in the brain to find out what's happening, how is it connected. So this is the brain of the Phineas Gage, where we managed to reconstruct this area. Then Henry Leborn, this is another area of the brain. And this is the third one with the middle temporal lobe gyrus damaged. So this is what we can do with the current technology and knowledge. All right. So why neurosurgery? So neurosurgery is an arrogant occupation. So people look in the stars to find out but you will be never able to touch them. Physicists see God in the vapor trails of the great atom smashers, but cannot see the particles themselves. They cannot reach into the protons and feel the quarks with their fingers. Molecular biologists sing the praises of the double helix, but the gene is forever an abstraction, invisible to the naked eye. So they must be content with the shadow nature cast upon the instruments and photographic emulsions, but not the neurosurgeon, for whom the greatest mystery of the creation resides in the few pounds over greasy flesh and blood. Only the neurosurgeon dares improve upon 5 billion years of the evolution in a few hours. So this is for me. Thank you very much. I hope I just give you some idea what's happening here. And this is it.
Thank you very much, Professor. That was honestly amazing. And it's great that we got such insight from your end, especially this is being our first event. I think you did it off amazingly. So I would like to thank you once again for coming in and making time out of your busy schedule to present this to us and allow us a little peek into the world of neurosurgery, so to say. I think all of us are extremely grateful to have you here with us. And the same thing for everyone who joined the meeting. Thank you. It was amazing to have you all. And I think that's it on our end. Once again, thank you, Professor. Thank you, everybody.
Thank you very much. Do you have any questions?
Actually, I had a few questions that I wanted to ask. So, I mean, you in your presentation you talked about like the fusion tensor imaging, the Connectome project, but I want to know for neurosurgery and especially before surgery and preparation, what are some of the more important tools that a neurosurgeon would use for preparation? Like, I mean, is diffusion tensor imaging always used? Is MRI something that you guys frequently use?
Everything depends on the condition we are dealing with. So if we have just a normal head trauma, we don't need any fancy tools. We just need a CT scan. We have to see what's happening there, and we have to crack on as quickly as possible. Whereas if we have tumor which is touching the eloquent area, we would like to know where the white matter tracks are crossing, and with the assumption that we know it's not 100% accurate, so we cannot completely rely on this technology, but definitely it's a great help. So it gives us the idea that the tumor is just separating the white matter tracks, or this is just a pushing away, so we can remove the tumor more vigorously because we see there is nothing within the tumor, or we can see that just in the midline of the tumor there is a tract which damage can cause some neurological deficits. So we say it's better to stay safe, and we stop sooner, even sacrificing the complete resection. So we know, all right, we stop a little bit earlier, we leave a little bit tumor behind, but we are sure that the patient is intact. Yeah? So this is the technology we can use. Then, so this is how we deal it. You have to tailor it for the appropriate disease. Yeah? For the spinal fractures, the CT scan is completely enough. Whereas when we look for some degenerative disease, we need a MRI scan.
I see. Thank you, Professor.
I also had a question, if I may.
Yeah, please.
I was wondering about the stem cell transplant for Parkinson's disease. Mm-hmm. You said it in your neuroregenerative segment, and I was wondering if procedures like those are happening in Poznań right now, or are they limited to other neurosurgery wards in other cities or countries?
So I am aware only that Professor Zombek in Warsaw was attempting some trials with this transplantation, but at the moment it was stopped. It didn't provide enough encouraging information to carry on with this project. Initially it looked promising, but then the effects were not very efficient, they're very good, so it is stopped. We don't do it. I personally believe that you really have a very good scientific lab in the functional surgery to create some new theory. Yeah, so we are more like in this area we are more like craftsmen. So we are only doing things which are already confirmed and approved. So we try to be as safe as possible. So we don't like, I don't like personally at the moment to try new targets and to experiment, because I know people who really are the big names in this field, which they have very sophisticated scientific background, and they have a very big lab where they do a lot of experiments before they move to humans. So I don't think we are good enough for doing the experimental neurosurgery in this area. But definitely like a bread and butter, when everything is confirmed and approved, we feel very safe with it. Yeah. So this is how it's happening at the moment.
Okay, thank you so much.
Anyone else? All right. Thank you very much.
Okay, thank you so much, Professor, once again, really. Hopefully the next time we'll be able to have another presentation in person. If possible, that would be amazing. And yes, I think that should be it. Thank you very much, Professor, once again.
Thank you very much. Nice to be with you. Thank you very much.
Thank you. Have a wonderful evening. Thank you, everybody.
Bye-bye.